Okay, so hello to all. My name is Dr. Kalina. I'm from Czech Republic, from Ústí nad Labem, and these are my conflict of interest. I have a research funding for um, project regarding a new technology for inserting central veins, and I have consultancy agreement with GHC regarding IOLPV, which I will talk today. So for you to know my background, I'm from Ústí nad Labem, which is a city near German border on the north of Czech Republic. The city is in very beautiful countryside, as you can see here. And I will talk about some projects that we did in my hospital. The hospital is about this size. This is the image of the hospital. And to know what we do in the hospital, we do about 25,000 procedures in general anesthesia in a year, and we do whole spectrum of the procedures there, except plastic surgery. The main focus of the hospital is on bariatric surgery, neurosurgery, and thoracic surgery. So these are the main procedures that we do and we focused on. And the projects that we performed here were mainly in these ORs and on these procedures. And now to the main topic of my presentation. It's how to improve adherence with digital solutions to IOLPV. But the first question to this topic is why we really should care about IOLPV in the ORs in daily clinical practice. And the answer for me is postoperative pulmonary complications. As you can see, according to this work, there are about 230 million major operations a year in the world in general anesthesia. The postoperative pulmonary complications has very high incidence in these procedures, and they are up to in 23% of the cases, which makes this complication, this adverse event, one of the most frequent adverse events at all linked to general anesthesia. It's even more frequent than cardiac complications that we care and afraid that much about. And we are talking about general anesthesia and no selection of procedures. But if we select subgroup of procedures, for example, laparoscopy or robotic surgery, the postoperative pulmonary complications are even more frequent than in general population, and we can come to incidence of PPC up to 30%, according to this paper. But it really depends on the type of definition you choose for PPC. If you choose like the most strict one definition for PPC, it includes also conventional oxygenotherapy. And then if you look at the subgroup patients that undergo laparoscopy or robotic surgery, then the incidence can be up to 70%. So the PPC are adverse events that are very important to our field and to our daily clinical practice. But still, you can say why we should care about PPC when we nearly never see patients suffering with PPC. Yeah, it's true. Most of the patients develop PPC later than we see the patients. They develop PPC in the standard ward in up to 5 days from the general anesthesia, or even after 2 weeks from the general anesthesia. And as you can see, the impact for the patients is huge, because this is a mortality and morbidity study proving that patients that suffered with PPC, that were undergoing abdominal or thoracic surgery, had significantly lower overall survival. We can compare. These are the patients without PPC. The overall survival was nearly 99%. But if you compare with patients that suffered with PPC, you can see that the PPC mainly occurred in 5 days and then up to 30 days from the operation. And then the overall survival was not even 70%. So we have dropped about 30% for PPC patients. So that's why we should care about PPC. And now, how to prevent the development of PPC for our patients. And for sure, we all know these two great papers that were published nearly. One was 25 years ago, and this is one from ARDS network, very famous one for sure. We all know the recommendations, and that was the paper that said the beginning for LPV in ICU for ICU patients with ARDS, but over the last 25 years, we know that this strategy is not just for ARDS patients, but also for healthy patients, and it's beneficial for the healthy patient in ICU. And as this became a standard of care for the patients in the ICU, we just started to move this strategy to ORs as well. And this reflects this paper down here, which is one of the, for me, most important papers that was published in last year that can influence the daily clinical practice. And this paper talks about recommendations that should be followed during general anesthesia and how to set the ventilator and to follow the lung protective ventilation in ORs. So this should be for us like the manual how to manage our patients and how to prevent development of PPC in our patients. So in my department, we made the standard operating procedure based on these two documents, how to manage the ventilation intraoperatively. Here are some of the recommendations. I would like to point out that we included in our standard operating procedure the PEEP. PEEP is mainly not involved in any paper that was published before for intraoperative ventilation. We set the minimum PEEP level as 8, which is based on the paper I just mentioned. Also, I would like to point out the frequency. Frequency is much more pressure on nowadays, as we know that we care about dynamics of the ventilation, so we have to count in frequency as well. So frequency initially should be about 15 breaths per minute, and what is very important for us is the recruitment maneuver usage, which is one pillar of IOLPV nowadays, and we can say it's more like a new parameter of IOLPV now. So the recommendations and the manual how to manage our patients are very well known, but we have to address one issue, and it's knowing, doing, gap knowledge. We know that even though most of anesthesiologists knows the recommendations, majority of anesthesiologists didn't comply with the recommendations, and we want to know how to improve the adherence in our department, and the answer was by education, which is proof that education can improve adherence to any recommendations and to some strategies, and it could be the same with IOLPV. But you have to first start with audit and to know where is the weakest point in your department. And if you look at the literature, there are nearly just two possibilities how to do the audit. You can go with questionnaire methods. We know all that questionnaires have some limitations. With questionnaires, the data are not objective that much. If you, for example, use automatic data recording, and the data cannot be manipulated by the responders. Also, we know that if we use questionnaires, most respondents that will respond to the questionnaires are very well trained experts in the field that questionnaires are about. So there's a big bias about like a really clinical day practice at the department. So we decided not to use questionnaires, and we were looking for some digital solution that would lower the burden for the physicians. And the solutions for us was CareStation Insights. You can see here the demo of the CareStation Insights. This is analytical software. It's working automatically. It recording data directly from the anesthesia machine and sending the data to the cloud solution. So the data cannot be manipulated. The recording is automatically, so you don't lose the data because of no responders and etc. And you have the data from every physician that is working with the machine. So it's a huge advantage. And you have the data at night, in shifts also, and the data are all the time with very high same quality. So you can use the data for processing. Another very good solution for this is that in the cloud, it's not just storage of the data. As it's analytical software, it counts the basic statistical functions for you as well. So you have a very quick overview about the practice in your department, and you can access the data from anywhere, from your laptop, from your phone, iPad, and so on, and you see the statistics just to your hand. So this is the overview. I would like to point out what we used mostly to manage our daily clinical practice in my department, and these are these dashes. And you have a compliance change, recruitment maneuver usage, ventilation measures for quick overview, and ventilation modes, just to know what ventilation modes are using. And these you can set the time period you want to be the statistic counted for. So, for example, we most of the time use monthly statistics to see where is the change moving. But if you want to select different ORs for different days and so on, and see very high detail statistics, you can do it also by selecting the ORs and so on. So what can you see in IOLPV dashboard in CareStation Insights, which is one that we use the most? It's lung protective ventilation overview for recruitment maneuvers. As I addressed, this is a one pillar for us, a very important one to perform recruitment maneuvers, and this was also the pillar that is forgotten to perform or followed like the most of the time. So you can see in how many cases in your department was recruitment maneuver used, and in what part of the procedure are recruitment maneuver used. In this dash, you can see ventilation measures like tidal volume, driving pressure, PEEP, plateau pressure, ETCO2. So you know where you stand with the practice if you follow the recommendations. And these are like the most common, very well-known recommendations. So it's and what we did in my department when we focused on education, and we wanted to know how we stand with IOLPV adherence. This is the data from USTI, the real data that we had before we started. So to explore the situation that we had, and we realized that we nearly do no recruitment maneuvers at all. And if we do recruitment maneuver, we do it manually with back squeezing, which is for sure not recommended at all, because the system cannot capture any recruitment maneuvers that were done. So it was one big issue that we have to address if we want to keep up with the recommendations. Also, if you can see, the PEEP levels were quite good even before implementing the SOP that we developed. But we have a very huge range of ETCO2, which is not common, or the maximums are much beyond the recommendation, and we wouldn't have this information without digital solution for data recording and managing IOLPV. So what can we do with digital solutions? We decided to make a change in our daily clinical practice, and then we plan to do some intervention because we were not very happy with the situation that we have in our clinic. And so we developed the SOP and the educational program to start the change in daily clinical practice, and then we again collected the data with CareStation Insights to see if our intervention has some impact on our clinical practice. You can see here the detailed statistic of ventilation measures before we did the intervention, and as you can see, these were the most very well-known qualities of IOLPV, and we adhered to these quite good. But the biggest problem, as I told you, was the recruitment maneuver. So we focused the education on and the SOP on recruitment maneuvers. So because we have the data that the recruitment maneuvers are like the weakest point in our department, we made individualized education for all the physicians with hands-on workshops where they can try to perform automatic recruitment maneuvers, which were delivered by our anesthesia machines. We use only ACES anesthesia machines in my department, so it was very easy to set automatic recruitment maneuvers and PEEP titration, and to recommend and to teach all the physicians in hands-on workshop how to use them and promote the usage of these strategies. And after we implement the education module and the SOP, you can see that we improved in the weakest points. As I addressed the ETCO2, the range is much narrow than it was, and we fit to the recommendations levels. And the biggest change was in recruitment maneuvers usage. As you can remember from the previous slide, We nearly use the automatic recruitment manuals and pipettation at all. And after this implementation and after this inside knowledge of the clinical practice in the department, we can move up to 42 cases with recruitment manuals usage. This is huge if we can compare to another papers that were reporting the adherence to IOLPV. Even though these papers gather the data with questionnaires methods, the adherence reported is about 15 to 20% at all. And in my clinic, we had overall adherence to IOLPV bundle recommendations at the start about 4%. So we were very low from the mean reported adherence level, but after the implementation we moved to 30%, and that would be not possible without this digital solution, because when we ask the physicians about the practice, about the knowledge, everybody knows what they should follow, and everybody will reply that they follow for sure. Another point that is maybe like a view for digital solutions for the future is benchmarking. For me, benchmarking could be beneficial. We can see that in 2013, which is about 13 years, benchmarking improved quality of care in type 2 diabetes patients. It was like one of the first field where benchmarking was implemented, but now we can look for some more recent paper. This one is from 2022, and it's a systematic review how benchmarking can improve quality of care in medicine widely, not in just one field. We can see that the conclusion made by this systematic review is that benchmarking is beneficial and may improve the daily clinical practice in fields in medicine, and maybe our field, IOLPV, and not just IOLPV, anesthesiology itself, and the monitoring in anesthesia and so on, can be the field to implement benchmarking. And today it's not possible to have benchmarking across Europe or maybe in some small regions, but this could be a way to use the digital solution for future. And we are nearly getting to the end of my presentation, and I would like to close with two quotes I like. And one is from Lord Kelvin, and he said that if you can't measure something, you cannot improve it. And you see that if we didn't have a good data from IOLPV, we wouldn't be able to improve our daily clinical practice. And the second one is from very well known economist Peter Drucker, and he said, if you can't measure it, you can't manage it. So it's not just about one-time performing audit, but to keep the change coming and last long, you have to measure the adherence to IOLPV and any other outcome you want to influence continuously, and to manage the change and the practice. And just to close, I would like to highlight the improvement that we made thanks to CareStation Insights and the technology that were provided for us. And we improved from 4% of adherence to IOLPV to nearly 40% in our daily clinical practice, which was for me a great success of my team. So thank you very much for your attention, and I'm open to your questions.